Renal denervation has been the subject of immense interest, but there remains a lot of uncertainty around the optimal technique and perhaps even whether the procedure works or doesn't. So in the October 20th, 2015 issue of JACC, a carefully done assessment on the impact of lesion placement on efficacy and safety of catheter-based radiofrequency renal denervation. And to talk about this, I'm with one of the study co-authors, Dr. David Kandzari, who is a Piedmont Heart Institute in Atlanta, where he is the Director of Interventional Cardiology and the Chief Science Officer. Let's start, before we talk about the paper, why did you do this?
The background for this is that on the heels of the Simplicity Hypertension 3 study, recall this was the largest pivotal trial of renal denervation, and it was intended for U.S. approval of this very promising technology that was widely used already in many parts of the world in clinical practice. This study did not achieve its primary efficacy endpoint. And we performed a number of exploratory analyses into that experience along with other clinical trials and real-world clinical practice experiences to better understand were there confounders of this trial and what might possibly have we done differently. And one of the issues was related, put simply, to the procedure itself. You'll recall that renal denervation is a procedure that has no practical biomarker of procedural efficacy. If we put a stent in a coronary artery blockage, we can see that we've improved that blockage, but we have no practical measure other than very sophisticated measurements of muscle sympathetic nerve activity or norepinephrine spillover that are not routinely used in nearly all parts of the world. So we have no measure of procedural efficacy that we're really contributing to renal denervation. And the history behind this then is, could we perhaps do the procedure in a different way? Might we develop newer technologies that might facilitate greater predictability of renal denervation? And might that then translate into improved outcome for patients with regard to blood pressure control in this particular instance? And the history of renal denervation is also interesting in the sense that, for catheter-based renal denervation, is that there was a great interest or focus on the ostium of the renal artery, and that there was a perception that this is where a cluster or the concentration of renal nerves might be at their greatest concentration, and therefore the therapeutic target might actually be at the origin of the renal artery. And so many operators, both in clinical trials and context of clinical practice, focused their ablations more perhaps on the proximal segment of the renal artery. And the failure of Hypertension 3 to achieve its primary efficacy endpoint was surprising to us, but in a way a little bit of a welcomed opportunity to revisit the preclinical science.
And our assumptions.
And our assumptions. And what we've recognized is that, in fact, the concentration of nerves is perhaps equally as great in the distal segment of the renal arteries and extending into the branches. But more than that, the proximity of the nerves to the lumen as a susceptible therapeutic target to, in this case, energy delivery, is even closer to the lumen and more proximate to to affect renal denervation in the distal segments and into the branches. And what we've also realized in the background of preclinical animal studies is that when we do catheter-based renal denervation, we do achieve quite significant profound reductions in norepinephrine content as a marker of reducing the hypersympathetic state. But there's quite a bit of variability from procedure to procedure, from subject to subject. And could we perhaps more consistently achieve greater reductions in norepinephrine content as a surrogate in these preclinical studies of renal denervation? And could we do it more consistently? And in fact, Bob Melder and others performed very elegant analyses then in a preclinical model of performing renal denervation not like before in the main segment of the renal artery and not simply concentrating on the very ostial proximal segment of the renal artery, but extending into the branches of the renal arteries themselves. This was an area where we had never previously gone with renal denervation. And they demonstrated, at least with the limitations of being a preclinical model, the safety of doing this, but perhaps equally of greater impact, aside from the importance of safety though, is that going into these distal branches, we achieve greater reductions in norepinephrine content than what we do in just treating the main renal artery. And moreover, we have a very tight cluster or we have a much more homogeneous response. We have very little variability from individual to individual when we do that. And so we termed this the IV trial. And we came up with the term, Bob came up with the term IV because is the long segment of the renal artery and the V is the branches. And then when you treat the branches plus the main segment, you have IV, right?
Right.
And so we came up with this nomenclature. And when we perform renal denervation in the main segment, but extend into the branches, this is again when we found the most profound reductions in norepinephrine content prior to what we've ever experienced before, and with the least variability.
And this is what you're reporting in JACC.
And this is what we reported in the manuscript.
So I guess the key seems to be the combination treatment of both the main renal artery and the associated branches. So now what's next?
So with that predicate experience, we're now moving into human clinical trials where we're doing just that. And in particular in the Simplicity Spiral program, this is an international study in a two-phase parallel trial design in which we're examining patients off medications with moderate hypertension, as well as patients on medications but on a fixed regimen of an ACE inhibitor, a calcium channel blocker, and a diuretic, and with moderate hypertension ranging roughly between 150 and 180 systolic, that we're randomizing these patients to control continued medical therapy versus renal denervation, analogous to previous studies. But in this instance, with the spiral technology, we're performing renal denervation in the main artery, but extending into the branches as well. And this will be our proof of principle, so to speak, in a human clinical experience, as well as determining the safety of this, or expanding upon what we believe is the safety of this procedure as well.
Well, there's an accompanying editorial by Neil Solani and Deepak Bhatt, and they wrote, "The experience in catheter-based renal denervation will continue to undergo bouts of rapid transformation. Ongoing studies in humans are currently employing new approaches as poised to undergo significant innovation in device application." And then they added, "Renal denervation appears to have reached a new branch point in its development." Would you agree with that?
I do. I think that's appropriate. And in fact, indeed, if we look at the number of publications just this year regarding renal denervation, it's far more than what we've ever seen. So it highlights this continued, or yet some ways renewed, interest in renal denervation, at least in academia, to continue and further support study.
Well, when I saw this coming down the pike in JACC, I decided I really wanted to get together with you. So thank you very much.
Thank you.
This is in the October 20th issue of JACC. Please check out the paper. And for all of the other material in Cardiol Source World News and Cardiol Source World News Interventions, where I'm Executive Editor Rick McGuire.